translation show there will not be any problem to follow our session. Esta sesión va de soporte respiratorio avanzado en la insuficiencia respiratoria aguda.
This session, Advanced Respiratory Support for Respiratory Insufficiency and Severe ARDS, will deal with three basic topics. The role of the microbiome on these patients with the need for ventilation support with severe distress by Dr. Adrián Ceccato. Then we will go into the world of individualized and precision medicine with transcriptomics, serotypes, and their influence on prognosis after the ICU. We will be listening to Laura Amado, who is an expert on this topic. And finally, a forgotten topic, which is analgesia in the respiratory critically ill patient with mechanical ventilation. We know that there are some late results that are very interesting. The talks will take about 15 minutes, and then we will have questions from the floor or from myself. So thank you very much to the organizers for this wonderful meeting dealing on miscellaneous topics that are of interest to many professionals. So let me give the floor to our first speaker, Adrián Ceccato, who will be talking about the need for ventilatory support in patients with severe ARDS and the crosstalk by host-microbe. Adrián, you have the floor. Thank you very much. Let me share my screen. Thank you for your introduction. I think you can see my slides now. As I said, I want to express my gratitude to the organizing committee for this invitation and for participating at this meeting. Since it's free and has a worldwide impact, I consider it extremely important. We have been holding this meeting for several years, and it gives everyone the opportunity to have access to new knowledge. I will be speaking about the influence of the need for ventilatory support in patients with severe ARDS on host-microbe crosstalk, which is the interaction between the host and the microbiome. I will focus on two studies we are conducting, transnational trials that may impact our patients. I have no disclosures. These are the fundings of the studies we are conducting. And as you know, lower respiratory tract infections are the most frequent in the ICU and have a severe impact on patients. They still have a high mortality, and therefore this is a very important topic to discuss. Patients who develop lower respiratory tract infections associated to mechanical ventilation have a variable incidence, but it ranges between 10 to 20%. And these incidents may increase, as in the case of COVID-19, which reached over 50%. So is a high incidence disease in our patients. The first study I will be discussing is the role of dynamic changes in respiratory secretory IgA bound to microbes in the development of ventilation-associated pneumonia. As we know, there are changes in the microbiome during invasive mechanical ventilation. This is caused by different factors. Some of them are typical host factors such as gender, genetic variability, comorbidities, smoking, lung inflammation, and acute respiratory distress syndrome, sepsis-induced immunosuppression, and gut dysbiosis, as well as other environmental factors, which could be the type of mechanical ventilation, higher oxygen tension, higher pressure, nutrient availability, edema, acidity of the epithelial lining fluid, and bacterial growth due to inflammatory molecules. Intravenous and aerosolized broad spectrum antibiotics, as well as impaired innate and adaptive host defenses or immunity. This is a more complete description of the causes. One of them are the oropharyngeal microaspirations in intubated patients, patients who are in coma or sedated. Bacterial elimination, there is an impairment by the decrease in mucociliary clearance and positive pressure, which reduces the clearance of the mucus. There is a gut-lung axis with translocation of the oropharynx and from here to the lung. And there are other factors such as nutrition, whether enteral or oral and digestive decontamination, and the use of different drugs such as proton pump inhibitors that may impact the microbiota. The pathophysiology of pneumonia caused by ventilation. Well, recently we know that it was the cause of intubating the patient and translocation of bacteria from the GI tract, from the stomach to the lung, and this caused the pneumonia. Now we know that this process is much more complex. There is a translocation from the GI tract into the lung, but that's a complete translocation of different microbes affecting the microbiome and producing dysbiosis, and may also be affected by other conditions such as the use of antibiotics, microaspirations, and the change in the environment. In patients with VIP, here we can see the effect of beta and alpha biodiversity. There is dysbiosis, and it's a major dysbiosis as compared to patients with no respiratory tract infections. And so via this stress, as we can see in this trial, there is a significant dysbiosis. So in the prognosis of patients, we can also measure based on the grade of dysbiosis of these patients. And how is the host-microbe interaction? In the different phases in the respiratory tract, there are different components. And the pulmonary airway, IgA, may play a very important role, both covering microbes as well as allowing for the growth of other microbes. These enables homeostasis and a crosstalk between pathogens and host, which is homeostatic. We know much more about the gut mucosa, which is more well studied, and IgA plays a very important role. Plasma cells secrete them, and they migrate through the epithelial cells, covering in the lumen of the organ the bacteria, particularly those which are more pathogenic, which regulates inflammation. And it also regulates the growth of the bacteria. And this allows for attacking dysbiotic bacteria. And on the other hand, enables the bacteria which are more homeostatic. And this is what we think is dysregulated in patients developing ventilation-associated pneumonia. These patients that develop pneumonia have lower levels of secretory IgA with the microbiota, leading to a higher concentration of inflammatory agents, dysbiosis, immunosuppression, and increase in pathogen bacteria. Our objectives are, first of all, to assess the dynamic change of the secretory IgA covering bacteria in the tracheal aspirate of patients receiving mechanical and massive ventilation to assess whether these levels of secretory IgA allow us to make a diagnosis of ventilation associated to mechanical ventilation, or VAP. We thought that this was going to be more advanced, but we are still studying. This is a prospective observational trial in which we enroll patients at the beginning of mechanical ventilation, and we compile data throughout the duration of mechanical ventilation until they develop pneumonia or extubated or discharged from the ICU. And then we continue following them to assess the survival. With regards to the methodology, we have adapted a technique which is described mostly in intestinal mucus, where we collect tracheal aspirate of the patients. We treat them with protease inhibitors, and we separate cells from bacteria. And then through a magnetic sorting, we use two stains with antibodies to separate the microbiome, either binded or not to the IgA. And what we are doing now is the sequencing of this microbiome. So we have prepared this technique for respiratory mucus. Here we can see the result through cytometry. This is the native segment or native portion. This is unstained mucus with no sorting. Here we see the actual fraction of microbiota binded to IgA with no sorting. This is the negative fraction, and this is the positive fraction. So we can see that the technique enriches the microbiome segment binding to IgA. Here we see the segment without sorting and without staining, the stained portion before sorting and after sorting. This shows the enrichment, and we have the microbiome binding to the IgA. Now we want to analyze the metagenomics for further information and data. Another trial I am going to discuss is the role of hypercapnia. Many of these patients may be hypercapnic with respiratory infections. These patients may have hypercapnia, many times secondary to distress, but because of ventilation as well. Many times we cause permissive hypercapnia to ventilate at low or ultra low volumes. And these hypercapnia may have an impact on respiratory infections. Some papers, and this is a review we completed last year, discussing many of the articles published that may have a beneficial and a detrimental effect, both. So hypercapnia may play a role on the activation nuclear factors, NF-kappa beta. To improve the trial, and we know that many times it's difficult to study patients with hypercapnia because they present many other conditions that may also influence. So we developed a co-culture of epithelial cells with macrophages that were infected with Pseudomonas or pneumococci. And then we place them in normocapnia or hypercapnia conditions. What are the results until now? Well, these are results which have been submitted and we are about to publish. It shows that in co-culture and in macrophages, hypercapnia has an impact on the secretion of IL-1 beta, as we can see on the different pathogens. But what's even more important is macrophages, as we see in the results of the lineal models that we have conducted. We have more than one covariable. We have infection and hypercapnia. So there is an interaction between Pseudomonas infection and hypercapnia, which results in a different secretion of L1 beta. these are the more interesting results we have accomplished, which are important and may affect patients. The survival of the bacteria, particularly Pseudomonas aeruginosa, there is growth and survival, higher growth and survival in cultures which are under hypercapnia. There are intracellular niches of Pseudomonas aeruginosa, which allows for persistence and growth of the bacteria. This situation is different in the extracellular samples, but after 24 hours, when analyzing the bacteria inside the bacteria, there is a higher growth of Pseudomonas. And these are the conclusions. The ventilatory support may affect the host microbe crosstalk by the bound to IgA to the microbiome, and hypercapnia may alter the inflammatory response of macrophages, particularly to Pseudomonas aeruginosa, which could promote the establishment of intracellular niches with a detrimental role in respiratory infections. And finally, I want to thank my team. I want to mention Verónica Moporte and Elena Campaña, the two people responsible for the studies, and Marta Camprubí, who is supervising the thesis of Elena with myself. And this is the research team who are constantly working with us on these topics. Thank you very much. Thank you, Adrián. Thank you, Adrián, for this very important discussion related to transcriptomics and the prognosis after the ICU in patients with respiratory distress. Laura, this is your turn. Thank you, Luis. Thank you, Paulo, and thank you to the organization for inviting me to participate in this session. It's an honor. It's been a few years now, and every day it's more enjoyable. Let me share my screen now. I think that you can see now my slides. Yes, perfect. I don't have any disclosures. And now I am going to talk about the a higher level work which involves the molecular and the cellular level of processes. One of the tools available to address these resolutions is transcriptomics, which has experienced over the last few years great technological advancement and a great impact on healthcare. This tool allows us to identify the mechanisms, activated routes of the different genes which are being transcribed, and we will see how this type of analysis may help us to predict outcomes, and finally, to identify potential therapeutic targets for a more accurate treatment. And I say accurate or precise because the objective of using these tools is to do precision intensive care. This term refers to adapting the treatment to the individual patient characteristics. It doesn't literally mean to develop a drug or a device which is unique for a patient or a group of patients, but the skill to classify individuals into subpopulations that have different susceptibility to a to a specific disease or the biology of that disease, or more interesting yet, the response of each individual or groups of individuals to a particular treatment. Since distress has been called distress, there has been a broad debate on the most appropriate way to classify patients. The advantage of not doing it, but simply using a syndromic definition, is that the clinical uniform recognition throughout the ICUs allows us to recruit a large group of patients for large clinical trials. And through the evolution of our specialty, intensive medicine, have provided us evidence about better ways or ways to improve the prognosis of our patients, reduce mechanical ventilation, restricting fluids, or use prone. However, the pharmacological strategies, we haven't been that successful to identify in non-selected populations of patients with distress the treatment that can improve this evolution. If we were able to classify individuals into subpopulations, we could focus on a specific therapeutic or preventive strategies to those groups that really benefit from that particular treatment, saving costs and adverse events derived from that strategy in patients that will not benefit from that strategy because they are already doing well. These enrichment strategies allow us to improve the efficiency of the designs of clinical trials and select populations that may benefit. And therefore, we have the opportunity to have a positive result, which we won't have if we use the treatment in a non-selected population. These enrichment strategies that increase efficiency of clinical trials may use tools such as transcriptomic analysis. And in fact, the use of classification strategies through tools such as transcriptomics is what we are doing. The historical evolution of intensive care can be described into three stages. The first stage is mechanical ventilation, continuous monitoring of physiological parameters, which increase the ratio nurses-patient, and intensive medicine is recognized as a specialty. These technological advances give us the foundation to improve our understanding of the physiology and save lives, which in the past would have been lost. A second stage, which arises parallel to progress in the field of translational research, which provides better knowledge of the molecular mechanisms involved in the disease, giving rise to scoring systems, quantitative, predictive systems, standardized definitions of syndromes, such as the definition of distress in 1994, and all of these allows for rigorous clinical and translational studies. And with this multidisciplinary approach, result in significant improvements in the prognosis of critical patients. Over the last few years, we have seen that although this is fundamental for research and clinical practice as we use it today, the classical concepts of disease do not allow us to capture the complexity of the critical pathology. So these syndromes, which are so typical in ICU, are characterized by clinical and biological heterogeneity. So we are leaving the beginning of this third phase, which has to be more disruptive than the previous one and requires a reclassification. We need classification tools to capture the biological heterogeneity of our patients and not just consider prognosis, but we also consider therapeutic targets that allow us to change the course of the disease, not just to know what is going to happen or which patients will most probably die. And at this third phase, which is our present, we have this possibility of using transcriptomics, a technique whereby the RNA of the cells, in this case of complete blood, if we use a blood sample, are sequenced through massive sequencing techniques to capture the profile of the gene expression of a patient in a specific tissue at a particular time. It could be the blood. This gives us a privileged window for the molecular mechanisms that are developing and identify groups of patients that behave differently in front of the same aggression. We know that in response to a systemic aggression, such as an infection, severe trauma, or any acute event, the different compartments of the immune system and the body act massively through genic transcription networks. These are very dynamic over time. They depend on the context and vary a lot from one individual to another. Transcriptomic allows us to identify which pathways are active and what processes are activated. And it also allows us to classify patients not on the outside, but in terms of what is going on at the cell level. This has been used in patients with sepsis. There are several trials to identify endotypes of patients with different pathogenetic mechanisms and different clinical prognosis. Even more important yet, the possibility to administer treatments that are more beneficial based on the cell processes activated. These are two examples published some years ago. Patients with sepsis, we identify specific biological response profiles. Another example is respiratory distress. In this case, this is a cohort we recruited in our center in patients with severe COVID. And the gene expression analysis allowed us to identify two subgroups of patients with different biological profiles. The classification of these two endotypes of distress responded not just to a number of genes expressed differentially, but also different immune processes, two phenotypes with two different immunological profiles. In one, there was a more adaptive and sophisticated response, whilst in the other, there was a more innate response mediated by innate mechanisms. Additionally, these two endotypes show different response to treatment with corticoids or steroids. These drugs induced a different gene expression profile based on the endotype of the individual receiving the treatment. As you can see, there was very little overlap. The change of the treatment with corticoids was very different on each phenotype. They have different ICU evolution. The endotype with a more pro-inflammatory profile with more innate response, less elaborated, is an endotype which has worse results and survival in the ICU. In the beginning of my presentation, I talked about the historical evolution of intensive medicine, which led us to this point in time, this transforming present we are living through. We are not longer interested in the large syndromes, but biological and individual differences and precision medicine. This evolution has gone in parallel with our need to improve not just survival in our patients in the ICU, but their quality of life when they are discharged. It's no longer just surviving or not dying, but being able to recover their quality of life before they came to the ICU. And in most of the cases in which we are able to discharge our patients, we have a pathway to total recovery, which is long, tedious, and it does not always accomplish success. The functional disorders of ICU survivors are multidimensional, covering physical, cognitive, and emotional aspects. And since we are a species that insists in making the same mistakes once and again, we have decided to frame all of these functional alterations under a syndromic definition. the post-ICU syndrome. This gives us a theoretical framework, and we even believe that by defining, we can control or improve the situation of the survivors. But the reality is that the post-ICU syndrome has more heterogeneity than distress or sepsis. The spectrum of neurocognitive alterations is so variable that it can comprise from no effect to a cognitive decline, similar to patients with head trauma. The same happens with muscle ability. The prevalence is equally high, and the loss of functional capacity is variable from minimal to persistent weakness in the long term. And the same happens at different levels. So, uh, considering all of these heterogeneity and the historical moment in which we find as with tools such as transcriptomics, we decided to use this knowledge to the identification of biological profiles of critical patients associated to different evolution.
To advance that knowledge, we have had to conduct a study in ICU survivors that has required 3 years in recruitment, biological testing, long-term follow-up after the ICU, and the analysis of all the data. And it has also been necessary to establish a collaboration network and do a multi-center design with the participation of these 3 centers in Spain that you can see on the screen. Thanks to this study, we have recruited and analyzed samples of 243 ICU survivors with the objective of breaking down the biological heterogeneity, in this case of the patients who survive. And behind that heterogeneity, which we believe is responsible for variability in long-term evolution, not only sequela, neurocognitive sequela, but also muscle sequela. When we consider ICU-derived weakness in this cohort of patients, we are able to identify using a latent class analysis 2 subgroups of patients with a different clinical course. There is a group where we see a functional recovery, long-term functional recovery, while there are other patients where the weakness persists over time. Follow the patients. These 2 clinical subphenotypes, because these are just using functional clinical variables, have overexpressed genes, and another set genes who intervene in the regulation of muscle, like transmembrane ions, transport, and who are also implicated in the immune response. This is another way to represent the activated processes in these patients. And we have taken a step beyond the analysis of biological samples. Up until this time, we have focused on transcriptomic data obtained from whole blood, because these are accessible samples and they allow us to quickly obtain the bedside. Since this approach doesn't allow to directly study the affected tissue, it gives us a panoramic view of the ischemic processes, which are particularly useful in post-ICU syndrome where multiple systems are involved. But the idea is to move forward to an understanding with a higher resolution and a subgroup of these patients, and we obtained a sample of skeletal muscle tissue, in particular the vastus lateralis, at the admission to the ICU, and then at 3 and 6 months. And what we applied was a transcriptomic technology with a higher level of resolution, which is single nuclei DNA sequencing. And instead of analyzing all the RNA of a mix coming from millions of cells, the single nuclei RNA sequencing allows us to break down the signal and looking from cell to cell to determine the profile of expression. So we can actually identify the cell subpopulations and also characterize the functional status, not only of the tissue, but of each cell population found in that tissue. By applying this approach to the skeletal muscle of ICU survivors, we were able to describe not only the different population of cells after critical illness, but we were able also to identify altered gene expressions in specific populations like satellite cells or skeletal myocytes or interstitial fibroblasts and compare the two clinical phenotypes. One of the most interesting results of these samples was the observation of the interactions between cell populations found in each clinical subphenotype during follow-up and between time points along the clinical course. So both subphenotypes showed intercellular interactions at the admission to the ICU, which are different from the ones that we observe after 3 months in each of those subgroups. And we can see, for example, in the group of persistent weakness, the skeletal myocyte population has interactions with other populations like the vascular endothelium or fibroblasts, which are not present in the functional recovery group, both on admission and at 3 months. In the same way, satellite cells in the functional recovery group, which are the ones that you see in blue, show that in the functional recovery group after 3 months, they create interactions with other populations, such as neuromuscular junctions or other fibroblast populations, whereas in the persistent weakness group, that cell population there are satellite cells, but they have no interactions with other cell groups. And these results enable us to approach cell processes that participate in the persistence of weakness after the ICU stay and perhaps point to targets that we can intervene in the future. Regarding neurocognitive sequelae, we were also able to identify 2 subphenotypes of patients according to their clinical course with different courses in terms of recovery of their cognition. These are subphenotypes that are different from those of muscle weakness. Those who have neurocognitive sequelae maintain it in the second period of follow-up with little ability to recover in our cohort, whereas those who had muscle weakness, recovery is observed after 3 months and up until 6 months and 12 months. When comparing the gene expression profile between the 2 groups of cognitive and subtypes of neurocognitive sequelae, we also find differences in a set of genes that appear overexpressed in one of the 2 groups at the time of admission to the ICU. These genes with differential expression among patients with different neurocognitive prognosis were implicated in the immune response, the regulation of sensory perception, and signaling and the mTOR signaling, among other processes. So now to come to the end, we could conclude that from the results of our analysis, there are pathogenetic phenotypes of long-term sequelae in ICU survivors that could be predicted at the time of admission to the ICU by means of transcriptomics in whole blood. Translation to the clinical setting of these results is complex, and I hope that it will come one day, but it requires a lengthy process that implies the identification of those transcriptomic signatures of a group of genes so that we don't have to sequence the entire transcriptome at the time of ICU admission, and requires technological development that allows us to have devices at point of care so that we can estimate those signatures and indeed predict or classify the patient based on who will benefit from one strategy or another. And not only that, all these signatures will require prospective validations in different cohorts beyond the discovery cohort. And of course, it will depend on the integration of this process into the healthcare infrastructure. And this will be even more complex, perhaps. So, take-home messages from this talk. Therefore, biological heterogeneity at the time of admission to the ICU explains the clinical variability in the post-ICU course. The transcriptomic analysis in whole blood would allow us to identify the biological heterogeneity in critically ill patients, coming closer to intensive precision medicine. And muscle transcriptomics in a single cell opens new routes to understand the cell basis and also the molecular basis of muscle weakness acquired in the ICU, and also to design targeted therapeutic strategies. I would be remiss if I finish this presentation without thanking all the team of individuals who have taken part in this project and continue to participate, as this is a long-term study and it requires long-standing effort and work. There are many more. I cannot place them in one slide. I wish also to thank all the institutions that have enabled us to develop this project, and of course the people who organize this type of event like this one today that allows us to communicate our results. Thank you very much. Thank you, Laura, for your presentation. We will now go on to a very important topic, which analgesia in critically ill patient, and Irene is now with us. Irene, good afternoon. Please be welcome, and over to you immediately. Good afternoon. I will share. I hope that you can see my slides. First of all, I wish to thank you for inviting me to this World Day. My name is Dra Dot. I come from Barcelona, from the Hospital del Mar, and my lecture is going to be different from the previous ones. I'm going to be talking about analgesia in the respiratory critically ill patient. My disclosures, and as you know, pain is a sensory experience, and it is a personal experience that is determined by antecedents or emotions and prior experiences. And the definition has been evolving over the year. The latest definition is of 2020, and we try to make more comprehensive definitions. Patients in the ICU, unfortunately, can suffer from pain more frequently because of experience, psychological factors, demographic factors, and the factors associated with the acute illness. But there are other situations that we can modify during our work to control pain and improve patient experience. The most prevalent origin of pain in the ICU has to do with procedures. Which are the procedures that cause more or less pain? This has been studied, and in fact, all of the procedures, if you look at the list, all of the procedures that we perform every day in our ventilated patients will cause pain. So the patient may have a baseline pain that we are treating, but whenever we perform any of these procedures, that pain can increase. So it is important to assess not only the pain, baseline pain, but before performing a procedure and after giving a treatment. And why do we need to treat pain? You know that pain has many consequences, and it has psychological consequences at the time of admission as well as in the future. Physiological disruption derived from the cortisol axis, and psychologically, the relationship between the patient and his or her situation, and this could have an influence on the patients who are in the ICU and increase the syndrome. So the treatment of pain is one of the pillars to prevent ICU syndrome. We need to detect, prevent, and manage pain. and we need to do this judiciously. Pain management is based on these three pillars: adequate detection, adequate treatment, and the right monitoring of the treatment. How do we detect pain? Well, you know that in the ICU there are many challenges, and one of them has to do with the consciousness state of our patients. Patients who have an altered level of consciousness or patients who are sedated will not be able to communicate properly, and that will prevent adequate assessment of their pain. But if we don't have protocols, and if we don't know when and how to assess pain, no matter how much communication the patient can give us, it won't be possible. So the importance of protocols has to be reiterated. What are the tools that we use to detect pain? Well, it depends. Patients who can collaborate, we can use more visual tools with them. They're easier, perhaps, quote unquote. And in patients who don't collaborate, we have different tools. The first three, in particular, the SKID in Spain, which is pain indicator behaviors, the only one validated in Spanish. Or else the other ones in English, PPS and the CPOT. The first three are behavioral, so we need to use them in these patients. If not, NOL, ANI, and papillometry that give us more objective values for pain. And how do we treat? Once we have detected the pain and we have classified it as mild, moderate, and severe, how do we treat it? Pain treatment requires multimodal approach. This is very important. We are not just going to give one drug. We also need to understand the timing, which drug, and if combined with others. The analgesia first strategy means prioritizing pain control before sedation. And this means that in patients in whom we are going to use mechanical ventilation, pain treatment before initiating sedation will enable us to improve discomfort, reduce anxiety, and in some patients, we will be able to use less sedation, and it shortens days on mechanical ventilation. And not only that, we should be using multimodal analgesia to target different points of nociception. So we will use not only opioid analgesics, but also non-opioid analgesics and also non-pharmacological interventions that can help with comfort and reduce stress in our patients. So it's not just treat with one drug, but it is a multimodal approach. In non-opioid analgesia, the latest guidelines from America recommend the use of paracetamol in moderate to severe pain in ventilated patients associated with the opioid for treatment of pain, and thus reducing the use of opioids, and also ketamine in postoperative patients. And the use of NSAIDs have been recommended routinely in these guidelines. In terms of neuropathic pain, in patients with Guillain-Barré syndrome, it has been found that the use of gabapentin, carbamazepine, and pregabalin can help and reduce the use of opioids and improve pain relief. But what happens with the patients who are on mechanical ventilation? These are patients that are already under procedural pain. And in these patients, we recommend the use of opioids at the lowest possible dose, or at least that is the recommendation. This is a study that dates back to 2001, assessing the consumption of opioids in the different ICUs in Europe. And as you can see, each country has a different tendency to use a different opioid. This still persists in 2024 in Europe. The use of fentanyl and sufentanil is similar, half and half, whereas in Spain, most people use remifentanil as compared to the rest? What opioid drug should we use? Well, it depends in particular on the patient and of the objective with the patient. It will depend on the intention and the intent, the timing of initiation, the time planned for ventilation, and patient comorbidities. If they have liver insufficiency, for example, or renal failure. And which to use? Well, in fact, looking at the different guidelines and the different studies, and what we can see is that morphine is an opioid that takes longer to have an effect as compared to the use of fentanyl. Fentanyl improves. It reduces days on mechanical ventilation and reduces length of stay in the ICU as compared to morphine. So probably fentanyl would be preferable above morphine. In case of remifentanil, as compared to other opioids, has shown to reduce days on mechanical ventilation, reduce days until extubation, and they can also reduce costs. And fentanyl, nonetheless, is limited to shorter ventilations. And we need to remember also that remifentanil has an increased risk of hyperalgesia at high doses and sustained. And so it's important to monitor when we use it in patients who receive analgesia with remifentanil during mechanical ventilation. In this article published in Intensive Care, they consider opioid drugs for first and second line, and they find that fentanyl and sufentanil could be considered first line drugs for patients on mechanical ventilation, and morphine and remifentanil as second line drugs because of the limitation of in terms of days of use for fentanyl, and morphine because it takes longer for onset of effect, and it might increase days on mechanical ventilation and accumulation of metabolites. And it could be, of course, an issue in patients with renal failure. If we take a look at the use of fentanyl as compared to fentanyl, even if it is not significant, we do see a trend towards earlier extubation and less shorter lengths of stay in the ICU. And it has been shown to be safe in longer ventilations because it accumulates less than fentanyl. So fentanyl, alfentanil can also be available in the ICU. We could use it, but we should think that alfentanil has a very rapid onset of action and a very short life, so it wouldn't be useful for longer mechanical ventilation. Fentanyl, remifentanil, and sufentanil, they can be used in mechanical ventilation. And as we discussed, in terms of long-term ventilation, we would be talking about fentanyl and sufentanil, and it depends, of course, on the individual patient. And non-pharmacological strategies are also important. These are things that we offer in the ICU, the use of massage, music therapy, cold therapy during procedures, and relaxation techniques. In our case, we also use animal therapy, and it has been found that it improves patient comfort, and therefore there is a lower requirement for analgesia. But in particular, once these drugs are used, it is important to monitor. As we said, before and after their use, we would use the same tools that we use for detection with the intent of reducing the dose as much as possible, thus avoiding adverse effects. As you know, opioid adverse effects include tolerance and reduced mobility. Conclusions: well, pain is another vital sign in the critically ill patient and must be assessed routinely. Baseline pain and also pain during procedures. Correct treatment of pain will enable the patients to improve their course, but the protocols are needed in the critical care units. The multimodal analgesia is a strategy to treat pain in the critically ill patient, and opioids are indicated in analgesia for moderate to severe pain in the critically ill patient. We need to individualize the opioid according to the patient and the clinical situation. And fentanyl and sufentanil are opioids of choice in long-term ventilations, although sufentanil has a better pharmacokinetic profile than fentanyl. Remifentanil is more effective than morphine and fentanyl in reducing days on mechanical ventilation, but it is limited to short duration intubations, and therefore monitoring of hyperalgesia is needed, and monitoring of pain and its adverse effects is essential for a good course in our patient. Thank you very much. Thank you, Irene, Laura, and Adrian, for your excellent talks. We have 8 minutes for questions, and I will start with questions from the audience that I'm seeing here. And there are some for you, Laura, but we will have some for Irene also and for Adrian. The first question has to do with cost. What is the cost of adding all this work in patient classification and this investment, all these things? How are we going to cover this cost? It's a management question, but very interesting, Laura. Thank you very much for the question. Of course, a very interesting one and very relevant. The incorporation of this equipment is not yet implemented, so still don't have experience in this, but it will depend a lot on the level of complexity that each hospital implements. I understand that if these technologies are integrated into well-designed clinical flows, there will not be immediate returns, but it will be progressive. That is what I believe. And I give you an example. If I have a transcriptomic signature that identifies a patient with a pro-inflammatory profile, and I have immunomodulating drugs that have a very high cost, instead of giving them to all the patients, I'm just going to give them to a few patients. So it will be immediate because the initial investment is high in terms of technology development and in terms of the scientific knowledge. But I think that it is the right direction. It should not only be viable, but it should be necessary, because we need a shift in paradigm to improve the prognosis of our patients, or if not, we will continue with the same mortality figures. I don't know if I have answered the question. I think it is ambiguous. My answer is ambiguous because we still don't know. And the answer is that, yes, we really don't know how much all this costs, but I believe that it is worthwhile. Thank you. The next one, how can physical rehabilitation, and I will add to the question from the audience, physical rehabilitation and cognitive rehabilitation in all the things that you have explained about these two phenotypes. Some have found more, because this is crucial. We can have point of care, but can we modify the environment and what we do based on what we find? Yes, of course. In our cohort, we haven't been able to analyze the impact of rehabilitation intervention on the gene expression profile, because it was a piece of data that was not collected a priori when we started this study. We were in the middle of the pandemic, and rehabilitation was none because there was no capability, and it varied for the entire population. So it was a variable that we were not able to measure. But surely it is interesting to do it if there is an intervention that will be able to modify the course of the disease. It will have to be an intervention that affects the systemic response of the patient. Maybe cognitive training systems or rehabilitation, early mobilization might have an effect, but it would be very good to know about this and apply it also in an individualized way.
One question. I loved your intervention, particularly after reading articles in critical patients. I'm glad to know that that's what we are doing. Somebody says we use a lot dexmedetomidine. What's your opinion? Well, the truth is that yes, dexmedetomidine, as we know, it's not just analgesic, but it's sedative. But it can also be used as analgesia. The difference is that different from opioids, the analgesic power of dexmedetomidine is lower. So it's very useful for the treatment of pain, but particularly associated to another opioid, a bit multi-model to reduce the use of opioids as analgesic alone. I wouldn't use it as the first choice, but I know it's a good option as a sedative and coadjuvant. We have more questions, but there are two that agree with your topic, Adrian. Two questions that speak about lung mechanics regarding your presentation. How can recruitment influence in everything you have been telling us in the microbiome? This is the response of microorganisms to hypercapnia. We would like to know in the clinic, this may have influence on what you have been discussing. Adrian, you are off. Your microphone is off. I'm sorry. Well, there isn't much evidence in principle. We know a lot about the microbiome, and we also know that patients with distress, and the more severe the distress, the more dysbiosis there may be. So that could be an impact, but we don't know whether this is a biological effect because of inflammation, or it could also depend on mechanical ventilation. We know that the higher the PIP, that could generate a lower mucus clearance, and this may affect the environment and the infection of the respiratory tract. But it has been seen that it may also have a biological impact. Laura has studied it, the impact of mechanical stress on the response of epithelial cells. So we know there can be more inflammation with consequences. Certainly, there is an impact, but we don't yet have enough information to say how much would it affect. And with regards to hypercapnia, well, it has been proven, and nobody questions it, the reduction in the current volume has improved the prognosis of distress. This is something we must keep in mind, but hypercapnia could be permissive, so we would have to further study that because there may be bacterial overgrowth and then the development of ventilation-associated pneumonia. Thank you. Our time is up. We don't have any more questions. Thank you very much for your excellent presentations and to the audience for your attention. And we hope to see you next year. Thank you very much. Thank you.